Everyone, welcome to ResearchMD.com. Another great presentation today. Let me introduce myself. My name is Dr. Pramil Cheriyath. I'm a practicing physician in the United States, a program director, internal medicine residency, and the transitional residency. I'm also associate professor of medicine, two large medical schools. So we're going to teach you everything about the treatment of hyperthyroidism. We gave a great presentation about hyperthyroidism, but the topic was too large, so we couldn't fit into yesterday's presentation. And today's presentation is all about how do you treat hyperthyroidism. Okay, let's start our presentation today. So when you look at it, just let's go back to the how the thyroid hormone and all that works. You have to know it's an anterior pituitary hormone. Everybody know that. Let's go to hypothalamus. You got thyrotropin releasing hormone that goes to the anterior pituitary. Then it stimulates the TSH, and TSH act on the thyroid gland, right? So when you talk about the treatment of hyperthyroidism, that means when you talk about hyperthyroidism, what happened? There is increased synthesis and secretion of thyroid hormones, right? So we need to stop that. So how do you stop it? There's three ways we can stop it. We can stop with antithyroid drugs, okay? Which are PTU, propylthiouracil, thiamazole, methimazole, carbamazole. Those three drugs. Okay. The other option is you can give radioiodine uptake therapy you can do, and the last one you have surgery. So we're going to go through all three methods. But remember, it's antithyroid drug, radioactive iodine, and surgery. Those are the only three options you have. All right. So let's look at the number one antithyroid drug. First, in order to understand, let's see how the thyroid hormones are produced, okay? Usually you got this thyroid globin and the iodine kind of come in and kind of join. And during that process, there is this enzyme, thyroid peroxidase. It kind of acts in like three major mechanisms. One is oxidation, other one is organification, and then coupling reaction. That happens, and then you got this T3 and T4 is produced. So when you give antithyroid drug, what happens is it inhibit the thyroid peroxidase enzyme, and then you got decreased production of T3 and T4. Okay, so none of the other issues kind of happen, doesn't go to. But PTU, remember, can also, if you give in large doses, it can go into the peripheral tissue and block this conversion also. Just remember that, okay? So remember, there is three processes going in the thyroid follicle, which are oxidation, you got organification, and the coupling reaction. It's done by pretty much this enzyme thyroid peroxidase. So this antithyroid drugs can inhibit it and block the conversion, so there's not much T3 or T4 is produced, okay? We give large amount of PTU in the peripheral T4, T3 conversion can also be affected that. Now, what are the drugs we use? We already said PTU, carbimazole, and methimazole. But one thing we can remember, always use methimazole or thiamazole as the first line therapy. The reason for that, their half-life is longer, so you have to dose only once a day. The other thing is you have to dose like 2 times a day. Who wants to take a medication if you don't have to take like 2, 3? Because when you have 2 or 3 times, you always forget, right? So methimazole is like once a day dose, and efficacy is better. So first line of treatment, I would always recommend methimazole. Now, there is 2 regimens actually. One is like titrated regimen. Again, that's the preferred treatment. The reason for that, there's the first line treatment, less side effects. When you use this block and replace, which is a second line therapy, it can have like serious side effects, okay? So don't go with the block and replace with the thyroxine LT4 treatment, okay? Now let's look at first you have to achieve the euthyroid state. Then what you have to do is then 12 to 18 months you have to treat it with with the current drug, maybe like a lower dose, right? Methimazole, you do like let's say, I think it's around you can do like around 10 to 15 dose, like a maintenance dose, but you have to treat for 12 to 18 months. And the problem is that I think Cochrane Review did a meta-analysis, and they looked at, and unfortunately, like 50 to 60% of the people can have recurrence. So let's look at what are those people, there's high chance of recurrence. If they have severe hyperthyroidism, you have a large goiter, okay, and then you got high T3, T4 ratio, and persistently suppressed TSH, and high baseline TSH receptor blocking antibody. Okay, So those are the very important, like, I mean, I'm just going to circle it right here so everybody remember. This probably like an examination question, like what are the things they can do. Now, okay, when I talk about antithyroid drugs, let's go to the pregnancy. Okay, if it is the first trimester, always use PTU. Okay, because the other, like methimazole, can cause it can be teratogenic, so do not, it's contraindicated in the first trimester of pregnancy, but you can use the second and third trimester of pregnancy. Okay, and the side effects you can use skin rash, agranulocytosis, aplastic anemia. Skin rash is like more common, and then hepatotoxicity, especially when you use PTU, and then ANCA vasculitis is also common when somebody uses the PTU. Just remember that. So we covered how this antithyroid drug were, I mean, all three, how does it work, I mean, what are their doses, and all this we just kind of covered it, right? Now, the next most important thing, again, is the radioiodine uptake treatment. Okay, so if you look at radioactive iodine, you got like two components. There is a beta and gamma. Beta is the one going to the cell and destroy the cell. Gamma just kind of light it up. Just remember that. Okay. Now, when do you use it? There are some indications for it. Let's say if you have Graves' disease, always go for this. This is the first line therapy. When you have toxic multinodular goiter or toxic adenoma, you should use radioactive iodine. Males less than 40 with the severe Graves' disease, you should radioactive iodine. You got predictable cure. It's like completely cure, right? Remember, what is the recurrence rate over here? Like 50 to 60%, right? If somebody said like, I just want to know the treatment is done, is taken care of, then go for the radioactive iodine. But remember, they have to be ready to use the thyroxine or levothyroxine supplement rest of their life. You need to let them know. Cheapest long-term management, very cheap compared to the other drugs and all that, okay? Now, contraindication, pregnancy, you cannot use it. If they're lactating, you cannot use it. Active Graves' ophthalmopathy, you cannot use it because it can worsen it, okay? And then cancer or thyroid or suspicion, don't use it, because it can increase cancer risk. And then pre-treatment with anti-thyroid drug. I think they used to do that before. Then they did the study and found out it was not. Maybe it's kind of making worsening. So there's no need to like a pre-treatment. Now, follow-up, you measure T4, T3 after 1 to 2 months. So always go for T4 and T3 because TSH in these people can be suppressed for a very long time. Even when we talk about anti-thyroid drug, right? Don't rely on TSH. That's very, very important, okay? And then you should start levothyroxine, like LT4 should be started as soon as the patient become hypothyroid. Don't wait, you start your thyroid replacement. And then side effect worsening of Graves' ophthalmopathy, probably contraindicated in that situation anyway, right? And there's some risk for like cancer, not high risk, but there's some risk. People need to know that. So we covered the radioiodine treatment, right? The next treatment is surgery, right? So what are the indications for surgery? You can do, the first thing we need to know, there's two types of surgery, total or partial thyroidectomy, okay? Don't pick partial thyroidectomy. I'm going to cross it out. You just only total, very important. The outcome is much better. So do total thyroidectomy in this patient, okay? And indication, again, large goiter, low uptake of radioactive iodine, most successful treatment for Graves' disease, remember, and suspect or confirmed thyroid cancer. Remember, if you got thyroid cancer, don't use the iodine treatment, right? And then you got moderate to severe ophthalmopathy, Graves, and patient prefers surgery, just go for surgery, right? And then pre-treatment, you have to make sure the patient is like euthyroid. You may want to give potassium iodate that decrease the thyroid hormone release and then decrease the vascularity, make it easy for the surgery. And the complications, always watch your hypocalcemia because when you do total thyroidectomy, parathyroid may be like removed. And then recurrent laryngeal nerve injury is very common. And post-surgery, you replace, it's very, you have to replace. There's no other choice, right? Because you took the thyroid gland. And measure after 6 to 8, you can follow with the TSH in this. And you always monitor calcium, which everybody know because it can cause hypercalcemia because hypoparathyroidism. Remember? Okay. So in a nutshell, let's go back and review. Let's take a step backwards. Look at our beautiful whiteboard. 3 treatments, right? Anti-thyroid drug. You got radioactive therapy and surgery. Okay, so let's look at the key points. In anti-thyroid drug, always remember methimazole, first line of treatment, okay? And then always titrated regimen. Don't use the block and replace therapy. And always look, what are the risks for high risk or high recurrence rate, almost like 50 to 60%, right? So severe hyperthyroidism, they're large goiter, okay? Then your high T3, T4 ratio, persistently suppressed TSH, high baseline TSH receptor blocking antibody, okay? And then when you come up your radioactive iodine therapy, there's two components, beta and gamma. And the beta is the one kind of kill the tissue cell death. The other one kind of glows it up. And then indication, if there's Graves' disease and toxic multinodal goiter, toxic adenoma, you want a predictable cure, and if you're okay with the lifelong thyroid supplement, do not use in pregnancy and contraindicated. And then the other thing, the last treatment option is, again, surgery. You got the indications given. Always remember total thyroidectomy, okay? Not the partial. Remember that. Because studies have shown outcomes in total thyroidectomy is much better. Large goiter, indication large goiter, low uptake of radioactive iodine, most successful treatments for Graves' disease. When you have thyroid cancer, choose this, because you cannot give radioactive iodine. Remember, pre-treatment with to make the patient euthyroid is important. After the surgery, watch out for hypocalcemia, because hypoparathyroidism, recurrent laryngeal nerve injury is also very common. Thank you so much for watching our presentation. Greatly appreciate it if you could subscribe to our channel, because it takes a lot of effort from a lot of us to make a presentation like that. And we wanted to cover all endocrinology topic this month. It's a big task. Please help us. Have a blessed day. Study hard.